everyone, thanks for tuning in to Shannon and Veronica Know Everything. This week has been a bit interesting, and I can't say why on YouTube, but future Shannon, you survived the week of fucking hell. So anywho, we're going through hepatology. It doesn't make any sense to me, but I have memorized it nonetheless, and I will help you memorize it. So to start off with, when we're talking about hepatology, we classify things into either cholestatic liver disease or hepatocellular liver disease. So cholestatic is going to be all the biliary ducts, the intra and extrahepatic biliary ducts. So for cholestatic liver disease, think the tubes, and that's going to be gallstones, PBC, and PSC. The reason we're going to suspect that we have a cholestatic problem on our hands is going to be high GGT and high ALK phos. Moving on to hepatocellular liver disease, much more common. This is the meat, so it's going to be a problem with the liver itself, not the ducts in the liver. This is going to be our alcoholic hepatitis, our autoimmune hepatitis, our viral hepatitis, which is B, C, A, mono, different viruses, DILI, drug-induced liver injury, or any of our hereditary conditions, Wilson's, hemochromatosis, alpha antitrypsin. So pretty much anything not involving the biliary ducts is going to be hepatocellular liver disease. And the reason, so it's the meat. And the reason we're going to suspect a hepatocellular liver problem is elevated AST and ALT. One thing to note, if AST is significantly higher than ALT, think an alcoholic problem. So I remember that because alcoholics drink AST, and AST is Coors Light. So that is cholestatic versus hepatocellular. That's just one way to think about things, but don't get too tripped up on that. It's better to know kind of specific diseases, but that's a good classification, if you will. And then the next thing we're going is that acute versus chronic liver disease. So less than 6 months, this is a very important marker to remember, is acute, and then greater 6 months is chronic. So our next thing to bring up is some of our dangerous labs. The reason we want to cover these is because at times the AST, ALT, whatever, ALK phos, GGT can be normal, but you see these labs changing, then you're going to be very concerned. So if you have decreased albumin, you have to start thinking, is my patient malnourished or do they have a liver problem? Albumin is made in the liver, so low albumin is indicative of poor synthesis. Also high PT-INR, this is our bleeding number, so higher the more risk of patient bleeding out. The reason high PT-INR makes you want to think liver disease is because the body can't control bleeding if there's not enough clotting factors, because the liver produces clotting factors. The next is high bilirubin. Our patient is likely going to be jaundice. This can be high unconjugated, conjugated, or total bili. You're going to start thinking, is there something wrong? And then low platelets is another dangerous sign. Also because the platelet patient could bleed out if they don't have clotting factors, you're going to think liver problems. So bilirubin, we have total bili, which is made up of unconjugated and conjugated. Conjugation is just like, if you will, this is a bilirubin molecule, and then I'll add a carbon methyl group that conjugates it. So before the liver, in the blood, we have unconjugated, and if there's high unconjugated, you're going to think hemolysis. And then once we're conjugated in the liver, if there's high conjugated, just think of a liver problem. And then high total bilirubin, you could kind of think of either, but that's when you have to get the breakdown of the bili. So then our stages of liver disease, we have a healthy liver. Say you eat like crap, you might get a fatty liver. You continue eating like crap and maybe drinking and smoking, you'll get a fibrotic liver. And then if you don't treat that, your liver will scar. The fibrosis will turn into scars, they'll harden, and that is what we call cirrhosis, also known as end-stage liver disease. So earlier stages is the fibrotic and fatty, the last stage is scarring or cirrhosis. So we're going to go through some of the hepatocellular conditions, and then we'll talk about cholestatic, and then some liver masses, and lastly, hereditary liver conditions. So the first one, this doesn't really fall into any category, is Gilbert's disease. It's a harmless genetic disorder of increased unconjugated bili with jaundice flares. So the way you can remember this is your friend Gilbert, whenever he has final exams or anything, he is drinking a lot of coffee, not eating well, Gilbert will turn orange. He gets cirrhotic and can have scleroictus, so totally harmless, just kind of have to control your stress levels. Very interesting, just remember Gilbert during finals gets really stressed and becomes jaundice. The next one is autoimmune hepatitis. So this is really common in females, you need to remember. The way we're going to suspect this is when a patient has high ANA and anti-smooth muscle antibody. And then the diagnosis, biopsy, and also, sorry, I don't really understand this one, but it's just kind of weird shit. High IgG, ANA, and F-actin. We talked about that. So treatment for autoimmune hepatitis is going to be prednisone and azathioprine. The next condition we're going to talk about is non-alcoholic fatty liver disease. So this is essentially the kind of fatty liver disease that I drew here. There's two types, NASH and simple fatty liver. So in NASH, that's non-alcoholic steatohepatitis versus simple fatty liver is just steatitis, some shit. Diagnosis, ultrasound, you will see the fat in the liver. Treatment, you just treat the underlying risk factors. So have the patient stop drinking, if they're taking a bunch of NSAIDs, stop having them take NSAIDs. No tobacco, boring. Just make sure if there's a question on this, it's lifestyle for non-alcoholic. So moving down here, we have viral hepatitis. This could be Hep A, B, and C. This could also be other things. What other viruses? So testing for this Hep A is just food poisoning, so we don't really care about that, whatever. That's basically in GI. But for Hep C, you test for Hep C virus. If that's positive, you have to go test the RNA directly, so Hep C virus RNA. And then Hep B, you're going to test the Hep B surface antigen, because that we know tells us if we have an infection. If that's positive, Hep B virus DNA. So remember, we'll go over those later. The next thing we're talking about is cirrhosis. So I mentioned here, cirrhosis or scarring is...
Sit down so I can see you.
Is end-stage liver disease. So cirrhosis, big topic, end-stage liver disease. When we're going to suspect cirrhosis or that it's gotten worse, is going to be those dangerous labs that we talked about. So low albumin platelets, high bleeding number, PTIR, and high belly. We get a lot of jaundice going on. Imaging, you're going to get an ultrasound or CT, and when you see the word nodular liver or splenomegaly, mostly the nodular liver, cirrhosis, they're fucked. So we have compensated versus decompensated of once we get the liver scarring. So compensated is stage 4 fibrosis, like within cirrhosis we have staging, we didn't talk about them very much, but just know compensating, the person maintains function in the liver, and patients still might be asymptomatic, which is crazy. Whereas decompensated, we get the GI bleeds, the hepatic encephalopathy, the ascites, and the jaundice. They're doing pretty bad. 2 scoring systems we have for cirrhosis is the MELD and the CPT score. So MELD is going to be your 3-month survival rate, and 15 plus MELD score means you need a transplant. And then CPT is going to be your 5-year survival without transplant rate. So I don't have any good way of remembering that. Maybe a semester's 3 months, so you have 1 semester to meld together class, so 3 months. And then once you have greater than 15 semesters, you need a transplant or some shit, I don't know. And then CPT, 5-year scoring, I don't know how to remember that. Anywho, cirrhosis treatment, liver transplant referral, so you're going to refer them to hepatology. An annual EGD, the reason for that, we need an upper scope to look for varices anytime a patient has cirrhosis. Q6-month scan for hepatocellular carcinoma. If you're in that last stage of scarring, it's very likely you're going to end up with cancer, take over your liver, and die. So we really, really frequently need to check for cancer. And then lifestyle modifications are also very important. So I'm going to move on to Veronica.
Hi guys, thanks for tuning in. So I'm going to go ahead and jump in, and we'll start with cholestasis liver conditions. This is going to be your PBC and PSC. So we'll go ahead and start with primary biliary cholangitis. So what you're going to find here is you're going to have an increase in anti-mitochondrial antibodies. You're going to go ahead and treat that with ursodiol, which is going to help with the itching. And you can also use other medications for itching, such as Zyrtec. One thing you want to know is you want to make sure that you're getting a bone screen every 2 years. The reason we do every 2 years is because we follow the Medicare guidelines, and that's what they will allow with insurance. One way to remember this is that Ursula might want peanut butter. So Ursula for the treatment, mitochondrial, want peanut butter for primary biliary cholangitis.
And female.
And she's a female, and this is more likely in females as well. So I'm moving down to primary sclerosing cholangitis. So this is where you have hardening of the intracellular and extracellular tubes. So this is more likely in males rather than females. You're going to find that about 75% of patients will also present with irritable bowel disease. So you're going to be doing yearly colonoscopies for these patients because they're at a higher risk for colon cancer. Diagnosis is you're going to be doing an MRCP or an ERCP, and then there's going to be this beaded appearance as well. As far as treatment, it's, how do you say this?
Ursodil?
Ursodil, so itching. So just remember these, they're both have itching, they have the same treatment. So now we'll go ahead and move down to liver masses. So you're either going to have malignant or non-malignant. So go ahead and start with malignant. The most common lesions are going to be due to metastatic reasons. So for example, breast cancer, colon cancer, lung cancer. Other than that, we have hepatocellular carcinoma, and this is the most common primary malignancy found in the liver. As far as diagnosis, you're going to go ahead and do an ultrasound. You're also going to do some labs. You're going to find that you have an elevated alpha-fetoprotein. And then that's going to be our malignant type. So we're going to move down to non-malignant. So first we'll start with hemangioma. This is just a benign vascular tumor that you find within the liver. We're going to go ahead and do an MRI or a CT to confirm that, and then typically just do no intervention. They should be totally fine and not present with any symptoms. Focal nodular hyperplasia, it's usually an incidental find. Again, patients have no symptoms, there's no treatment necessary for that. The next one's going to be hepatocellular adenoma. This is going to be a capsulated nodule liver lesion. So this specifically is related to oral contraceptives, hormonal IUDs, or antibiotic steroids. You want to go ahead and stop those. As far as any contradictions with pregnancy, if the lesion is less than 5 centimeters, I believe, you can still get pregnant and there's no concern there. So now we'll go ahead and move over to hereditary liver conditions. So we have 3 here. We have Wilson's, hemochromatosis, and then AAT. So to begin with, Wilson's, this is copper overload, specifically with the free serum copper. So you really want to distinguish that from like a total. And then with labs, you're going to find that you have a decrease in ceruloplasm, and then an increase in your 24-hour urine of copper. A specific sign that you'll find with this is going to be Kayser-Fleischer rings in the cornea. So that's going to be pigmentation that I believe is like brown or green within the eyes. And then as far as treatment,
and you have bronzing of the skin, right? Bronzing.
Okay.
Fake tan. Wilson got a fake tan.
Yeah, Wilson's got a fake tan with his copper to match him. As far as treatment, you're going to use a D-penicillamine, and that chelates the copper, also known as trientine. And then you're also going to be using a zinc acetate, and that just prevents absorption of copper. So now we'll go ahead and move down to hemochromatosis, and this is an iron overload disorder. So presentation, they might just be asymptomatic. You can find that these patients are fatigued, they may have impotence, they have bronzing of the skin here, and then arthritis as well. So diagnosis.
Oh, Wilson's is probably not bronzing.
Wilson's might not be bronzing, FYI.
It's hemochromatosis. Sorry.
As far as diagnosis, you're going to have transferrin saturation that's greater than 45%, and you're also going to have a huge increase in ferritin. As far as the treatment, you're going to be doing weekly phlebotomy. Typically, the goal for the ferritin is going to be between about 15 and 100. If you have patients who are unable to do weekly phlebotomy, such as like an elderly individual, they have the option to do iron chelation as well. And now we'll go ahead and move down to AAT. This is low levels of alpha-1 antitrypsin. And so there's lots of different genotypes that can cause this, but Z is the most common and it's the most harmful to the liver. They are usually going to find that the patient, it's going to affect the liver and lungs of the patient. Therapy is just going to be avoiding alcohol and smoking. If the patient does have lung disease, they have the option to have an infusion of AAT. So today we went over hepatology. There was a lot to it, so take it with a grain of salt. So thanks for tuning in.